In this patient, we see multiple densities throughout the right lung. Some are quite large and have the appearance of a pulmonary mass. What could this be? This could be multifocal pneumonias, could be infarcts of the right lung, less likely metastatic disease. Why are these densities considered to represent the pulmonary thromboembolism? Because of the appearance of the left lung. The left lung shows a total oligemia, and at the post-mortem examination, the right lung was riddled with infarcts. Some infarcts were seen in the left lung, which occurred several hours after the chest rentgenogram was obtained and the patient subsequently died. So clues to the diagnosis of abnormal densities in the lung are going to be the associated oligemia as observed in the entire left lung of this patient. This patient had a rounded, ill-defined density in the mid-portion of the right lung. What could this be? It could be pneumonia, it could be hemorrhage, it could be a neoplasia. Why would we favor the possibility of pulmonary thromboembolism? Because in the inferior aspect of this density, we see an area that looks like atelectasis. And the association of atelectasis with the pulmonary density should favor the diagnosis of pulmonary thromboembolism. Atelectasis occurs as a result of bronchoconstriction at the site of ischemia. This patient had an ill-defined density in the left base. The differential diagnosis would include a pneumonitis, could include a hemorrhage, less likely a tumor. The patient had acute left chest pain and had evidence of phlebothrombosis of the lower extremities. And therefore one would have to consider the possibility of pulmonary thromboembolism. But what is the pathological basis of this density? In pulmonary thromboembolism, in the initial stages, we have a capillary leak, and we may have edema. We may have disruption of the capillary bed, and hemorrhage will occur. And later on, hemorrhagic necrosis may occur because of hypoventilation. This is particularly seen in patients who have impaired pulmonary blood flow, as seen in patients with cardiac decompensation. So this ill-defined density, although it is not specific for pulmonary thromboembolism, if we associate the density to other findings, we must suspect the possibility of pulmonary thromboembolism. At the stage of edema or hemorrhage, the ischemic episode may not result in hemorrhagic necrosis. So resorption of the edema and hemorrhage may explain the rapid resolution when patients have a pulmonary thromboemboli and are treated quickly with anticoagulants, and particularly if the lung is properly ventilated. This patient had tachypnea and a nonspecific infiltrate in the lower third of the right lung. Note the position of the minor fissure. The normal minor fissure should be equidistant between clavicle and right dome of the diaphragm. This minor fissure is closer to the right dome. However, we do not see elevation of the right dome. Nevertheless, there is a volume loss of the right base. This is a close-up of the right lung. Note the ill-defined density in the lung, and note the thickening of the minor fissure, which was due to fluid. Whenever we see ill-defined densities in the lung, evidence of pleural effusion that can be seen in the costodiaphragmatic angles may or may not involve the fissures of the lung. And the patient has tachypnea. The densities of the lung out of proportion to the tachypnea suggest the possibility of pulmonary thromboembolism. A regular pneumonitis is less likely as a diagnosis because pneumonitis generally do not reduce the lung volumes, and a focal pneumonitis often is not associated with tachypnea. So once again, tachypnea out of proportion to parenchymal changes or the lack of parenchymal changes, one should suspect always the possibility of pulmonary thromboembolism. This patient developed chest pain in the left base. The upper row shows no abnormalities. The middle row shows in the left lung an area of discoid atelectasis. The bottom two images shows a reticular pattern of the right lung and the disappearance of the atelectasis of the left base. This is a close-up of the right base, and you can see a reticular pattern that if we did not know that this patient did not have cardiac disease, we would suspect acute interstitial pulmonary edema. However, the reticular pattern only appeared in the right base, and the left base appeared radiographically normal. Because of the history of pulmonary embolus to the left base, the reticular pattern of the right base was interpreted as also related to pulmonary thromboembolism. What causes reticulation of the lung in a patient with pulmonary thromboembolism? And this usually is due to interstitial pulmonary edema and or hemorrhage, and it can resolve completely or may become a pulmonary infarct. This finding of focal reticulation has been described as incomplete infarction or pre-infarction. Both terminologies we believe are erroneous. It is not a pre-infarct of the lung because it can resolve rather quickly, and it is not an incomplete infarction because there may be no infarction whatsoever. So reticular pattern may be observed in the early stage of pulmonary thromboembolism, and they represent the capillary leak of edema and blood that either will resorb, or if the patient is not treated appropriately, and particularly if there is underlying lung disease or hypoventilation, infarction may occur. A frontal image of a perfusion scan shows photopenic peripheral areas in the lower half of the right lung. There is also a photopenic area in the left base close to the... A pulmonary angiogram was performed at the time the reticular pattern of the right base was seen. There were no filling defects. There was no abrupt interruption of vessels in the early and in the late phase of the pulmonary angiogram. A close-up of the right lung following selective injection of the right pulmonary artery shows flow retardation in the lower half of the right lung. Note that in the third image, when we see pulmonary veins, we still see persistent filling of the pulmonary arteries that are best seen through the diaphragm. This means that a shower of emboli probably was the cause of the reticulation. The persistent arterial filling means that there is obstruction to the distal pulmonary circulation. Where could that obstruction be? It could be at the level of the venules, at the level of the capillary bed, or in the precapillary region. Obviously, this patient we knew had emboli to the left lung, so we have to assume that the cause of the peripheral arterial opacification, the persistent visualization of the pulmonary arteries in the venous phase, was due to a pre-capillary obstruction of small size pulmonary artery. This is a sketch which demonstrates the mechanism of the Fleischner line. Felix Fleischner was a giant in chest radiology, originally from Austria and practiced in Boston. And he described in pulmonary thromboembolism the frequency of discoid atelectasis. To your right, we can see evidence of the atelectatic segment and the presence of a bronchial obstruction. Now, the bronchial obstruction is not due to a mucus plug or from any other cause. It's the result of a bronchoconstriction. The bronchoconstriction occurs when ischemic lung releases bronchoconstrictors such as histamine, prostaglandin, etc. And it is an attempt of nature to interrupt the ventilation at sites where gas exchange will not occur due to occlusion of the pulmonary circulation. So discoid atelectasis are very important indirect signs, and when seen 2 or 3 weeks after a major surgery, we have to suspect the possibility of pulmonary thromboembolism, particularly when they are associated with tachypnea. Once again, tachypnea with negative or minimal radiographic abnormalities such as discrete infiltrates, bibasilar atelectasis, one must always rule out the possibility of pulmonary thromboembolism.